The reverse alginate guide technique begins with a good quality impression. We're going to take the impression, and before we pour it in stone, we're going to take some orthodontic wax, some rope wax, and put a little stainless steel pin in it. We're going to stick that pin into the alginate with the wax sticking up where it'll be poured in the stone. This is the location, the approximate location of where the implant will be placed. We're going to use snap set stone to pour the impression. You have to be fast with this snap set because it's going to set very quickly. But this enables me to make the guide while the patient waits, so I can have a cone beam taken in the office or send them out with the guide. Here's the impression with the pin sticking up. You can imagine that wax plug down inside the stone. We're going to pull that little stainless steel 036 stainless steel pin out, and we're going to place a 2mm post. This is actually a piece of coat hanger, which is 2mm. We're going to place that, and then we're going to put this Blue Sky Bio stainless steel sleeve over the post. The post is placed to where we think the implant should go by looking at the model and studying the anatomy, etc. We're going to put some undercut wax in the adjacent teeth because we want to be able to pull this guide off without damaging the model. We may want to make another one. This is the fastest way to make the guide. This temporary material is fast set. It sets very, very quickly. It comes out already mixed, and you can make a nice streamlined guide over the teeth. And you note the stainless steel tube that's sitting over the post representing where we think the implant should go. As this guide is made, the material that has already been put on is just about setting as you come across to the front. It's a very fast-setting temporary material and perfect for this technique. Here is the guide, completely finished in just that amount of time. We're going to take the guide off the model, and it won't damage the model because of the undercut wax that we've put on. That's very important. And when we take this model, we're going to take a look at it and make sure the guide looks like it's in good shape, smooth it off anywhere where we might need to, pretty much ready to go. And we're going to take the guide and put it in the patient's mouth as you see here. We're now going to have a cone beam taken, and we're going to take this cone beam in the office with your own personal cone beam, or send the patient to an office nearby that's got one. When we get the disc back, I like to load the cone beam data into Blue Sky Bio. The software is my choice. You can use any software you want to, perhaps the software that came with your x-ray machine. But what I like about Blue Sky is its simplicity. Here we've picked an example of an implant, and for the abutment, I have put a 15mm long 1.5 millimeter in diameter abutment, so it sticks out like a rod. The implant can be changed in length, width, and whatever, just like any of the software programs. But what we're going to do is we're going to place the rod, which is the abutment, we're going to place it in the software where that rod passes down to the center of the tube, which is showing up in the x-ray. When we get this implant placed where we can spin around the axial orientation of the implant and the abutment, that will tell us exactly where the implant would be if we used that particular guide to drill our pilot hole. So I can adjust the height of the implant. It looks like it's a little bit short. We can change the implant later, maybe try a longer one. Right now what we're focusing on is getting it oriented to where as we spin the patient around the shaft, it stays in the center of the metal tube. That's the reason we had the implant, the guide taken with the cone beam. It was in the patient's mouth when the cone beam was taken. So now we're centering it up just perfect. This little slider off to the right is what rotates the patient around. It got off just a little bit right there. So let's maybe scoot it over, but it looks really, really good. We're going to scoot it over just a little bit right there. But boy, that looks like a nice placement of an implant. Now, if you wanted to make a change, if by looking at this software you said, boy, it needs to be a little bit more of the distal, or it's going to hit that cuspid tooth or whatever, you can easily make the change on your model because that post is in wax. It's not a hole you drilled in stone. It's in wax, and it can be easily adjusted, and now you make a new guide. That's the importance of the undercut wax. You don't damage the model. So now we're going to try a little longer implant. But this looks like a really nice opportunity to put an implant in and use the guide, in this case, just exactly the way we made it. Now we're going to go to surgery. I know the guide is going to guide my pilot drill, so I'm going to flap the area. I'm going to place the guide in the mouth, but first I'll look at the bone and make sure it's flat and nice and see if there are any irregularities or anything that I need to be concerned about. Then we'll place the guide in the mouth, just like that. And there's the little metal tube. We verified its position with the cone beam. So now I don't have to have my assistant say a little bit to the left or a little bit to the right, or I don't have to change all my angles. I simply put the pilot drill in the tube and drill. Now, I can previously determine how far that drill will go by just measuring it on the guide with a Bowley gauge at chairside. And very probably, I may want to go a little bit deeper than what the guide will allow the pilot drill to go. I like to use the American Dental Accessories O-rings for my depth. I like B, C, and D. I order them from American Dental Accessories, and I just slip them over my drill, use a Bowley gauge to determine the exact length I want, and when the little rubber O-ring reaches the surface of the bone, then I know that my depth is perfect. The guide pin is put in, actually a twist drill put in there. I'm just going to take a visual look to see if, by golly, that angle is as good as we think that it was originally. And it's looking pretty good. We would expect that it would. We would expect it to be the exact same model, exact same angle that's on the model that we verified with the cone beam. So now, the object now is to enlarge the osteotomy to place our implant. Let's look at how I suggest the easy way to follow a pilot hole accurately. This is a balsa wood model. We're just going to simulate flapping the tissue back. We're going to take a look at the bone and see if the bone augmentation procedure was successful or what the condition of the bone looks like. Any preparation of the site that we want to do, we take care of. Now, we take the guide, we put the guide in the patient's mouth, or in this case, the model. And now we'll take our pilot drill and we'll simply drill down through the metal sleeves to drill the first pilot hole osteotomy into the jawbone. Once again, you may not be going to full depth because the guide may stop the drill from going all the way down by the collar. But now you would just put the pilot drill back into the hole, and it will fit snugly, and then just determine how much further you need to go for your 10 millimeter or 13 millimeter implant and drill that extra distance. Once the pilot hole has been drilled, we can put some pins in and check if we want to see the perfect alignment. Now this is a straight drill. A straight drill will not enter the pilot hole in any way. It will not self-guide itself. Now straight drills do have these drills like you notice marked here that have a pilot in the, it's a non-cutting tip that will tend to help guide the drill. But perhaps a really good choice is any type of tapered drill. A tapered drill is a side cutting drill. Some of them have drill stops that come on the drills. If not, I would just use the O-ring if I needed to. But the tapered drill already fits halfway into the pilot hole. So if you're doing a 10 millimeter osteotomy, you're only going to drill down 5 millimeters, and half of it's already done, and it's aligning the drill for you. It's going to follow that pilot hole very nicely. As a matter of fact, it's difficult to change the angle when using a good tapered drill with a pilot hole. But you line it up and just let it guide itself right down to the hole. After you drilled that enlargement, you would move to your next tapered drill, which would also fit halfway into that, because now the osteotomy is a little larger. The next drill will also fit halfway down and just naturally go to place. You would follow that sequence until you have done all of the sequences for your particular size implant, and then you would place your implant into the osteotomy. A good tapered drill, which is side cutting, not tip cutting, it won't go any deeper, it'll follow the hole, is a nice choice. Now, another type of drill that I like a lot is what we call the step drill. This is a step drill. Notice that the end of it is smaller than the other half of the drill. What happens is the tip of the drill fits into the previously drilled osteotomy. So the first drill will have a 2 millimeter tip, and it will fit into your pilot hole just like that. And now you only have another 5 millimeters or so to drill again, just like the tapered drill. It will align itself, and if you use a nice gentle pressure with your drill, it will just absolutely follow that pilot hole, because you've already got a hint with feel as to how it's going to go. When you get your next drill out, the tip of that next drill will be larger to fit the osteotomy that you just drilled, etc. You'll continue this process with your step drill until you've enlarged the hole for your implant to be placed. Because the drills naturally want to follow a pilot hole, you've reduced your skill level down to that. Can I follow an accurately placed pilot hole? In this case, it looks like it was a job well done. Those drills are just as parallel and in the exact same position as they were from the very beginning. It looks like we've got a nice parallelism here and a good successful case underway.